moving on to imaging of intracranial hemorrhage. First, you want to talk about the imaging appearances, right? So this is from Osborne. All of the modalities they've described very, very nicely. So this you definitely have to remember, right? So write this down in before your exam and revise this. This is extremely important. But before that, what is the mnemonic that you know here? I bleed, I die. How to differentiate sarcoid? Very difficult. Biopsy. You have to biopsy, right? Very good. I bleed, I die, bleed, die, bleed, die. I'm saying this after a very long time. Glad to know that all of you remember this. So this we know, right? So this is our T1 and T2 signal intensity. Now let's correlate everything here. So hyperacute is less than 24 hours, which is oxyhemoglobin, which is hyperdense on a CT. I bleed. So intermediate or ISO on T1 and bright on T2, and this we already knew. It blooms on gradient image and it is not going to show you, and it is going to be bright on DWI, dark on ADC, right? So it will show you pseudo diffusion restriction in hyperacutes. Basically, diffusion restriction is the feature of late subacute predominantly, but yes, even in hyperacute you can see. T2 star is gradient, right? So this is what is your gradient image. Okay. Any of you here who have still not joined radiology, who are starting before counseling? Because in conceptual medicine, I was seeing that there are few overexcited students who have just started studying beforehand only. अभी ऐसे कोई babies तो नहीं है यहाँ पे? Okay. Other or exam going or undergoing stress. Oh my God, have they started studying already? Okay. So this is hyper acute. Okay. So this is hyper acute. Fine. And then you have, it is same as how we see na ki NEET UG wale bacche, do you know what? Just like today only one NEET UG girl called me ki ma'am, what is to be done? I said, you shouldn't be knowing me at this point. If you know me already, it is not a good sign. So that's how, they are asking ki abhi se kya karna hai. So that's what, no, the same residency is also gone into same thing. Abhi baad mein seat lenge, but first let's start studying. Anyways, so hyperacute is done. That is oxyhemoglobin. Acute is deoxyhemoglobin. By the way, if you are there, don't worry. We are dragging you and get used to it. So it is fine. It's good to get a head start. So acute is 1 to 3 days. And it is deoxyhemoglobin. So this is also going to be hyperdense. I bleed, I die. So this checks out. And then this will bloom. It is further gonna bloom. So T2 star, to answer your question, is a gradient sequence, right? Susceptibility comes under the umbrella term of T2 star. So this is going to bloom. This is dark on both, right? So this diffusion signal intensity is important, that now it's going to be dark, except for hyperacute and late subacute. This is going to be dark. So we can just close the chapter of diffusion here only. Early subacute is very, very important. This is where you have intracellular methemoglobin. It now becomes ISO and it is bright on T1. This is very important. Can this also show us contrast enhancement? Yes, this can also show us rim enhancement, isn't it? So subacute is where you may also have, if you give contrast, you will see rim enhancement here. Late subacute, now this methemoglobin comes extracellular and now this is hypodense on CT. So CT पे क्या याद रखना है? Hyper, ISO and hypo. This we already know. Bleed, die. Okay. Then on T2 star, now the blooming has become so dark and now the dark rim variable center and it's dark. Okay. So this is something which is nothing special. Chronically, we will have hemosiderin. So chronic bleed में क्या दिख रहा है? It is dark on every modality, right? Whatever you do, it is going to be dark. So that is easy. It is dark on CT. It is dark on every MRI sequence. That is chronic. So let's revise. Everybody, timeline reh gaya. Less than 24, 1 to 3 days, 3 days to 1 week, 1 week to months, more than 14 days to once. Okay. So sabse pehle, everybody sorted with T1 and T2. I bleed, I die, bleed, die, bleed, die. So T1, T2 ho gaya. Tell me about T2 star. What are you going to write? T2 star, here the blooming begins, Then it further increases, more dark, dark rim, and just dark. ठीक है, so this is done. Then diffusion weighted में क्या बताना है? Where will I see diffusion restriction? In first and in fourth, right? Everywhere else it is going to show us no diffusion restriction. CT में बहुत simple है, पहले दो में हाइपर रहेगा, तीसरे में आइसो एंड फिर हाइपो. What is first one because of? That is oxyhemoglobin. Then deoxyhemoglobin. Then we have methemoglobin, which is intracellular and extracellular, and then it becomes hemosiderin. Is this clear? Will you be able to make this box? If you make this box, your job is done. Your examiner is impressed. Your question is answered. And then we just have to now see different cases. Now you have to write what all can be intracranial hemorrhage. So how are you now going to write? Is there any difference between EDH and STH? Yes, we are going to see examples and I'm going to show you, okay, how the signal intensity may change. Okay, so we'll see examples now. Encephalomalacia with hemosiderin versus chronic hematoma becomes very, very difficult to distinguish. But encephalomalacia very rarely will bleed, right? So it is very unlikely for it to have hemosiderin. Then it is chronic hematoma only, isn't it? No? So chronic encephalomalacia will not have hemosiderin in it. Otherwise, you can't distinguish because then it's chronic hematoma only, right? So now, how are you going to write your answer? So you have to say extra-axial bleed and intra-axial bleed. Within extra-axial bleed, you are going to talk about extradural hematoma, subdural hematoma, SH. Within SH, you're going to talk about traumatic SH and non-traumatic SH, right? Then intraaxial bleed, you're going to talk about hypertensive bleed, non-hypertensive bleed. In a non-hypertensive bleed, you can talk about cerebral amyloid angiopathy. You can talk about AVMs. You can talk about dural AV fistulas. So this is what we are all going to talk about. So this is the broad classification. CT में HU होता है, right? If you remember in our head trauma class, I had shown you one image that it drops by 1 Hounsfield unit per day, something like that. I had shown you one image of Osborne only. उसमें लिखा है value. I think it's 1 HU per day. There is some HU per day wala math which I've forgotten, but I think it's 1 HU per day. Just see the head trauma class. उसमें एक figure दिखा है. Yeah, 1.5 HU, right? So you can see there. Fine. So now let's seeing the images. 1.5 HU. एक बार देखना है ना. इसमें दिखाया था एक Osborne वाला image. So what do you see here? So this is a CT scan. This is a flare image. And here you can see a gradient image. So what do we find here is that there is this hyperdensity, sulcal hyperdensity, which is representing an SAH on both the sides, in fact, on the right side and the left side. And you can also see that there is a scalp subgaleal hematoma, right? So that is what we are seeing. And in addition, you can also see that there is a subdural hematoma, which seems to be there. So there is a right-sided SAH, a left-sided SAH, as well as some component of SDH seems to be there, which is very hyper-intense on flare. So you can see that it is hyper-intense on flare, and you can see that there is subgaleal hematoma. Okay. And what do we see on gradient? Upon gradient, we see that it is showing blooming. Both of these are showing blooming foci, right? So SDH and SH are showing blooming foci, but not the subgaleal hematoma. Subgaleal hematoma is something which is not. HI also I'll cover in the, but HI aaj isliye nahi kara because it was covered, no, in that myelination wala class. Dr. Shashank has covered, but still fine. I can do an overview in the next one. Okay, I can do it. वो मैंने highlight भी करा था, but today I skipped it thinking that it was already covered. So fine, we can do that. So this is what is a case of traumatic SH. Look at this case. What do you see here? So there is a hemorrhagic contusion, and what is this? This is an anterior temporal EDH, very common site of an EDH, right? So remember, this is a very common site, anterior temporal extradural hematoma. And this is where you can see that there is an associated fracture. And whenever you see an anterior temporal EDH, very good. It is likely to be venous EDH. You have the sphenoparietal sinuses, right? So that is what can bleed here. So this is what can be a venous EDH. And this is showing us the Coop counter Coop mechanism. Okay. This is another one daily. It actually, my schedule is very, very busy till 25th. So after 25th, I could have taken, but till 25th daily to bahut tough hai, but I will try to fit in a couple of extra sessions. Okay, I can do a few extra sessions. Okay, I'll put that in the schedule whenever possible. Okay, so today I'll just work it out. So what do you see here? You can see that there is this extradural hematoma with swirl sign, and you see this mass effect. Okay, so the swirl sign here indicates active bleeding, and look at the mass effect. What is this showing? This is showing subfalcine herniation, right? So you can see that there are signs of active bleeding, subfalcine herniation, and you can see that the effacement, there is effacement, significant midline shift. Okay, so effacement of the ipsilateral lateral ventricle and midline shift. What else do you see here? On the coronal, you can also see that there is a uncal herniation, right? You can also appreciate uncal herniation. So this is EDH causing significant mass effect. So this is how EDH is going to appear, hyperdense wall sinus when it is heterogeneous. Next case. So this is where, what do you see? You can see how there are hemorrhagic contusions, there are some sulcal hyperdensities, and we can see that there is some bit of a hematoma here, but we see it better when we do this windowing. What is this windowing? This is the subdural windowing, right? So you can now appreciate the difference. Look at these images in conjunction. You can see how all of the hemorrhages, especially the SDH here, you can't really see it in this and you can't really see it in this, but you can definitely appreciate it better. So do you remember these values? So what is the normal brain window settings? So the normal brain window settings, you want to remember as far as the width and the level are concerned. So what is the window width? That is 75 and the level is 20, right? So let me write here. So you have to remember these values. I have also not remembered them. So this is normal brain where you have 75 and 20. This is the normal brain window width and this is the window level. Whereas in the subdural window, right, you want to remember we make it wider, so it becomes 150 and 30. So this is what you want to remember. So yeah, 150 to 200 is a good number to remember. So subdural, your W width will be 150, your L level will be 30. So this is about the subdural window. You should remember these numbers, okay? पूछते हैं वाइवा में कई बार. So this is about if it's on bleeding or something like that, your case is going, they may ask you. So this is about SDH. Look at this one here. So this is another case of a subdural hematoma. You can see there is significant mass effect. Again, you can see effacement of the ventricle and descending transtentorial herniation. So this is another traumatic SDH with uncal herniation and subfalcine herniation, right? So this is example of SDH. Then what do we see here? So this is something where we are showing the evolution of a hematoma in trauma cases. So this is at admission and this is 24 hours later. So now you can appreciate that initially this is the degree in the left anterior frontal and temporal bleed. And now you can appreciate that the degree of the hematoma increases. So this is the normal evolution where a hematoma usually is expected to increase and reaches, when does it reach the maximum size? It reaches the maximum size in this window. After this, it declines. Okay, so the expansion of a hematoma happens at 24 to 48 hours. So that's the learning point here. Look at this case. So now we are on to intraaxial bleed. In intraaxial bleed, you want to remember the most common cause is hypertension. So this is a hypertensive bleed. You can see how it is centered around the right-sided basal ganglia. So basal ganglia is the most common site. So you can see it centered around right basal ganglia with edema. What I'm trying to show you is something called as the spot sign. On giving contrast, can you see how there is this bleeder that you can appreciate in the center? So this is the spot sign, and in a little delayed post-GAD image, this is the CT angio phase. A little delayed image, you can see how it is pooling, the contrast is pooling. So this shows you the bleeder. So this is what can pick up the source of a bleed. Then another contusion, another hemorrhagic contusion, and you can see how on gradient image and SWI you are seeing that there is a lot of blooming within the intracranial bleed. Okay, so this is showing peripheral. So can you guess the stage based on this? Is acute only, वैसे, but still such an appearance if you see in complete, remember the late subacute where you will see the dark rim and the center part liquefies. Okay, so this is the kind of appearance, even though this is acute, but just remember when you see central liquefaction, peripheral dark rim on blooming, this indicates a late subacute stage. So now let's talk about cerebral amyloid angiopathy. When will you suspect? What do you suspect in this case? A hypertensive bleed or a cerebral amyloid angiopathy? So this is where you're going to suspect cerebral amyloid. Okay, so one of the main things is non-BG bleed in an adult. That's the buzzword. Okay, non-BG bleed plus an adult is cerebral amyloid angiopathy unless mentioned otherwise. So this is the Boston criteria. So you can get a theory question on CA. So let's talk about that. What does the Boston criteria say? So definite cerebral amyloid angiopathy, the sites are important. So lobar, cortical or cortico-subcortical hemorrhage, or severe cerebral amyloid angiopathy with vasculopathy. So this is what is a post-mortem diagnosis where they are going to stain that in the vessels there is deposition of amyloid beta 42. Okay, this is what is going to deposit in the vessels. Probable CA with supporting pathology. So clinical data, pathological tissue. So same, essentially the same sites. You want to remember lobar, cortical, cortico-subcortical, right? So basically just moving around, saying nothing typical. Just remember the essence is non-BG bleed. Okay, that is what you need to remember, and just give the name that you know it's Boston criteria and that's right stories. Okay, so this is cerebral amyloid angiopathy. Look at this other case of cerebral amyloid angiopathy. There are two cases. This is one case, this is another case. So this is where you can see that there are these small vessels which are affected. So you can see this small vessel, ischemic, demyelinating changes around the periventricular aspect, and on blooming, can you see this? So now you can see that there are so many areas of blooming which are not appreciated as such, right? So you can see, you can appreciate this on SWI. Okay, just 1 second, slide is. It's okay. So this is SWI, which is showing you this blooming in there are peripheral cortical areas where you are seeing these small micro bleeds. Another case where the changes are not so convincing, you can see these small periventricular demyelinating changes, and again, many small foci of blooming. So this is what you see. You see these many small vessel changes. This is how CA increases, right? This is how it progresses. So you want to remember, always do the screening SWI to look out and detect cerebral amyloid angiopathy. Okay. Then what do we see here? So this is where now we are talking about hemorrhage. This is ischemic hemorrhage. So this is secondary hemorrhage in ischemic stroke. So there is a grading for this as well. So this is what is called as HI1, HI2, PH1, PH2. So look at this, the grade 1, HI1 is where you're going to have particle hemorrhage along the infarcted tissue margin. Have you seen this grading? Have you seen this grading before? So this is where you can see that there is ischemic. Okay, if you have seen, that's great. Okay, so this is where you have ischemia, and around the ischemia, you can see that there are some particle hemorrhages. Oh, if you reported, that's amazing. I have never reported this. So this is what is HI1, particle hemorrhage along the, if you give this grading, it's amazing. So this is particle hemorrhage along the infarcted tissue margin. HI2 is where now you have confluent particle bleed. You can see that it's a big bleed, right? So that is HI2. Parenchymal hematoma involving 30% or less of the infarcted tissue with slight mass effect. So now you can see that there is a hematoma which is extending into parenchyma. It is not just in the basal ganglia. That is what is the word P for. So HI1, small bleed. HI2 is big bleed, but within the basal ganglia. When it goes into the cortex, into the parenchyma, that's PH1. When it goes into the parenchyma with significant mass effect, look at this. This is the infarct, and you can see big bleed has gone inside the ventricle. It is intraventricular extension, and you can see mass effect. So this is what you want to remember. So this is a grading that you can remember for secondary hemorrhage following ischemic stroke. Now talking about SH, which is non-traumatic SH. So most commonly you have to rule out a berry aneurysm, a saccular aneurysm. So you can see that there is a confluent bleed around the basilar cisterns. CT angio shows you a small collection of contrast, which is angio, which in this 3D angiography you can see is your aneurysm, right? So this is the aneurysm in the ACA. Here you can remember about the fissure grading. So this is the fissure grading: no SH, localized thin, diffuse thin, localized thick, and diffuse thick. So this becomes your diffuse thick, and this can also predict the grade of vasospasm, right? So this is just the name you want to remember, which is the modified fissures for SH. Next, what do you think is the diagnosis? So you can see that there is a lobar bleed here. Upon doing CT angio, we can see that there is a vessel here which is very prominent. And now on DSA, what do you notice? On DSA, we can see that there is a slightly early draining vein. Can you appreciate that there is an early draining vein which is going here? So this is a very subtle AV malformation, right? So this looks like a nidus here, isn't it? So rather than an AV fistula, looks more like an AV malformation. So this looks like a bleed from an AV malformation. You can see this very subtle nidus here with a early draining vein. On the other hand, look at this, another cortical bleed, and you can see on the CT angio that maybe there is this cortical vein which looks a little prominent, right? So now look at the DSA here. What do we see on DSA? So upon doing a DSA of the ECA, external carotid artery, what do we appreciate? No, very difficult to say that this is a vein, but you can see this is very cortical based, no? So you can see that it's something, it's in hindsight, can't say actively. Okay. So now what you can see on ECA that there is a vein, right? Can you see this? So there is an early discharging vein which is actually draining into. So now you can appreciate this is the cortical vein that we were probably seeing. So this is the right sphenoparietal sinus. So this is draining into the right sphenoparietal sinus and having a cortical vein, which you can now appreciate very nicely on the DSA of the ECA. So this is what is your dural AV fistula, which can again lead to intracranial bleed. So this is your right sphenoparietal sinus and the prominent cortical vein, which now in hindsight, probably we can appreciate that maybe this dot near the bleed must have been this vein. Okay. Artery versus vein, how to distinguish? That's always on a DSA run, right? Otherwise, we can't say, but looking at the pattern, you can say, isn't it? So this is your meningeal artery. This is your middle meningeal artery and the branches. And now you see the territory. This is the course of the sphenoparietal sinus. So on the basis of the anatomy, we can see that probably there is a connection here. And then on a delayed run, right? Once the artery is done on a delayed run, you will now appreciate that this is the cortical vein. Okay, so it's always on a loop that you will appreciate, but based on the course, we can appreciate as well. Okay, so this is a dural AV fistula. Do you know a staging system for dural AV fistula? One second, huh? Right. So this is the Borden and Cognard classification. Okay, so you can also read this right here why we are discussing. Cognard is used more widely than Borden actually. So this is where, just go through this once. Let's discuss this. So you can also, this might be a question on dural AV fistulas. So type 1 is where drainage is only into dural venous sinus with normal antegrade flow. 2A is dural venous sinus only with retrograde flow. This is dural venous sinus with antegrade flow with cortical venous reflux. So this is all seen on DSA, right? It's just theory at this point. It's all seen on the loop. You have to see whether there is any cortical venous reflux or not. And whether there is venous ectasia, whether it is going into spinal perimedullary vein. So this is a good schematic that you can see. Venous drainage into the dural sinus with antegrade flow, retrograde flow with your retrograde, basically cortical venous reflux, venous drainage into cortical veins, venous ectasia, spinal perimedullary veins. So this is a DSA based diagnosis, that is Cognard classification. Okay, so just want to remember the name and just get oriented to these terms. Okay, so antegrade flow, it is the direction of the flow, right? So look at this. Retrograde flow का मतलब है, antegrade flow का मतलब है that it is going in the direction. The venous sinus is supposed to drain into the jugular. So that is how it is flowing. Retrograde means now because of the higher flow, instead of draining into jugular, now it's coming back up. That is the meaning of retrograde. So in DSA, you will see that, okay, this is emptying into a dural sinus, but then now how is the dural sinus flowing? Is it going as it's supposed to into the jugular, or now because of the higher flow, it is going ulta? From the jugular, it's coming up. So that is the meaning of retrograde and antegrade. If it's going into cortical veins, so our type will become type 3. Na? From the sphenoparietal sinus, now it was going back into cortical vein. आ रहा है समझ में? अगर dilatation हो गया venous ectasia and spinal medullary. Okay, understood? So this is what is the meaning, okay, of how, what you have to see on DSA. So in this case, now if we appreciate, we can see how there is flow. It is retrograde. Can I say this is retrograde? Absolutely. This is retrograde into cortical veins, but the cortical veins are not dilated. So our case is going to be somewhere here, okay, this one, type 3. Next. So another case of bleed where you can appreciate that there is definitely something in the left frontal sinus, left frontal gyrus, but right side probably something is there which is better seen on the MRI. Very good, very good. This is where you have to suspect a dural venous sinus thrombus rather than CVT. Look at this here. Now you know the case. So whenever you see this bilateral infarct in this venous territory, you see blooming. And look at the post-GAD, we can see complete superior sagittal sinus thrombosis. So this is what is superior sagittal sinus thrombosis. So another case of bleed, something that you always have to suspect when you see bilateral bleeds, right? Always rule out cortical venous thrombosis or dural sinus thrombosis. Okay, this is very important. Another case, what are we seeing here? So you can see these multifocal areas of hyperintensity, some of which are showing areas of bleed, and you can see on the DSA, look at this irregularity, right? You can see that the terminal M4 territory here is showing this very, very irregular tapering. Look at this zoomed image. So this is what is a case of vasculitis actually. So vasculitis, another cause of bleed, right? So what did we learn about the causes of hemorrhage? Extraaxial versus intraaxial, we learned the appearance. In extraaxial, you have EDH, SDH, SH. In intraaxial, you want to talk about causes, hypertensive, cerebral amyloid, talk about the staging, talk about AV fistula, talk about the staging of AV fistula, talk about staging of dural AV fistula, vasculitis, right? Venous sinus thrombosis. So this gives you enough material to answer this question.